But
so it's whitish because of the formalin fixation.
a little more whitish. Not, of course, that's the vessel, the fat are really whitish, but all the cavity are a little whitish. So, summarizing about this case, we made to say that there is severe right ventricle enlargement.
Yeah. And then we have to probably give our main differential list. I don't know the age of the dog, so
sorry. If we imagine a very young dog.
So that I'll probably consider two differentials, which is tricuspid valve dysplasia or pulmonic stenosis.
Yeah, pulmonary stenosis. It could be. I don't see very well the post-stenotic dilatation of the pulmonary trunk because the picture
that would be probably unless it was a very advanced pulmonary stenosis with already dilation. That's the only possibility, I think. But I think tricuspid valve dysplasia will be more likely.
I agree with you. And the extracardiac disorder?
Pulmonary hypertension.
Good.
Yeah.
Another one. Thank you, Joao.
Thank you.
Another one.
So if you want, I can try with this, that it looks relatively slightly more
Jonathan.
obvious.
Jonathan.
Okay. No, this is not me.
Okay, who is?
It's Mattia speaking. Nice to meet you, everyone.
Mattia, nice to meet you. How are you?
I'm very good. Thank you very much. Thank you for the presentation. It's been very cool. I don't know, guys, if there are some of us that will do the actual certifying exam this year. So maybe I just thought that maybe you want to go ahead rather than me, that it will be another year. I don't know. I just don't want to steal your...
Doesn't matter.
Even go. Come on, go on.
It's an occasion. So come on, guys. It's a possibility, an occasion, a time for us to discuss the certification. Of course, it's important, but before there is the knowledge. So that's the occasion for us, also for me, for improving my knowledge, because you. So don't.
I don't think I've got too much to teach you, but I'm very sure that you've got plenty to teach me. Okay.
Okay, Mattia, describe this finding.
So here we have got a canine heart. There is a sagittal section. We can see both sides of the cut. The cut is showing all our four chambers. Obviously, the most abnormal finding is present just above what I believe it is the left atrium. This lesion, the most obvious lesion, it's a rounded, what it looks proliferative, large, rounded mass again, that doesn't look like invading the inner face of the left atrium, but it looks rather compressing it from outside. The coloration of it, it is, I don't know if there is some staining there or if it's just like that. It looks red.
Sorry, Mattia, can I say?
Obviously, yeah.
I'm sorry. In this case, the color is very interesting because in the periphery is whitish, in the middle is reddish.
Yeah.
Sorry, that's because of the fixation. So the formalin fixation starts from the external and so go inside. So the real color of this lesion is the reddish.
Yeah. Okay. So yeah, the coloration of this lesion is therefore red. That would suggest a highly vascularized mass. So I think, I mean, it is compatible probably with a neoplastic lesion. I guess that's one of the differentials. Other differentials could be, I think, granulomatous processes, although maybe a bit less likely, but it's still possible. And I think probably those are, well, I mean, it doesn't really look like, we could consider, let's say, a thrombus, but it's unlikely consider that. To me, it looks external to the actual chamber. It doesn't look like forming inside the left atrium. It looks like it's outside and is compressing it. So I think, yes, my main two differentials would be neoplastic and granulomatous.
Sorry, Mattia,
yes,
I agree. I'm sorry, I agree completely with you. So think about the question. The question is macroscopic diagnosis.
Macroscopic diagnosis.
Yeah.
So I think there is a mass. I think, can we just say mass? I don't know if it's correct.
It's correct. Okay. Mass, nodule are important words in the description. That they are keywords important.
Yeah.
Nodule,
so
mass. You describe correctly the lesion, in my opinion. You describe also differential diagnosis. But think about now about the question macroscopic diagnosis.
Yes. So. Well, yeah, I would say I don't know. I mean, I don't know what to add, to be fully honest.
Yeah, put together
the rest of the heart that to me looks slightly unremarkable. Maybe the left ventricle is slightly thickened, but I don't think that's the most relevant finding, or maybe it's just subjective. I don't know. And I obviously would focus on the presence of these rounded, large, vascularized mass on the roof of the on the dorsal aspect of the left atrium.
Okay, another keywords is dorsal. So the mass grow from dorsal to ventral direction with compression of the roof of the left atrium, with compression also of the interatrial septum. Of course there is, but it's not evident, the compression of the vessel in the base of the heart, of course. Okay, but if you think about which is your link inside your brain, the link between this lesion, it's obviously is a neoplastic lesion. I agree with you, because it's not a granuloma.
Okay.
Mattia?
Yeah.
Okay, Mattia, it's not a granuloma because it's not a granuloma, because the granuloma have to show a capsule and very clearly, and irregular yellowish material. We say also caseous necrosis, so something like cheese. Something like cheese. It's not abscess because it's not purulent, of course. It's not a generic cyst because there is not fluid material inside. And so, of course, that's a neoplasia. Solid, compact, proliferative lesion with some kind of discoloration, whitish, reddish, okay. But it grows from dorsal to ventral. And so, which is the easy macroscopic diagnosis? That's a heart-based tumor.
Yeah.
At the gross examination, that's a heart-based tumor. Histologically, histologically, of course, is a chemonectoma. Is a chemonectoma. Yeah. Of course, is not a hemangiosarcoma, because I will show you also many hemangiosarcoma. It's not hemangiosarcoma because it's not a typical area for hemangiosarcoma, because is from the right atrium and right auricle. That's in opposite dorsal position.
Yeah.
Mattia,
Yes,
So
yeah, that all makes sense.
And so for me, the correct macroscopic diagnosis is heart-based tumor. If I ask which is the most likely diagnosis, I have to say chemodectoma.
Yeah.
But Mattia, for you, look, take care. For you, it's a benign or malignant tumor in this presentation, this picture.
Well, from this picture, I would call it malignant.
Why?
I don't know. It's just
50%.
I know that chemodectomas are generally not as malignant, but I don't know. It looked to me that it was
Look around.
Maybe with the color of the ventricle, no, because it's wet too.
Say again, because I didn't listen. Sorry. Who's speaking?
Sorry.
Who's speaking?
It's Marine.
Marine, good morning.
Yes,
How are you?
Good morning. Fine,
Good morning.
thank you. I think it's maybe malignant because I'm a bit concerned about the color of the left ventricle. No, it's red too. It's maybe strange.
The color of the ventricle.
Yes, and leaflet is really red.
No, it's more easy, Marine. Marine, it's more easy. Look here. Did you see?
Yes.
What do you see?
Well, I see I think that to me it looks like okay, it's kind of invading the
invading keywords is invading infiltration of around the lesion, invading infiltration of the wall of the left vein of the left atrium. That's a good macroscopic presentation of an infiltrative growth of the neoplasia, and that's a suggestive of malignant evolution.
Nice. I wouldn't have thought that. Yes, I wouldn't have probably noticed that, to be fully honest. But yeah, that makes totally sense.
Yeah, but Mattia, is normal because the aim of the workshop is to improve our ability to see with a picture.
Yeah.
Because that's a specific kind of communication. That's normal. Don't worry. But I think that after the workshop, you are more able to think the picture, to understand the finding. Okay,
yes,
another one.
Thank
another
you.
one.
Can we just go back, please? It's John.
Okay.
Should we add as well? There is a atrioventricular disease, myxomatous disease, on the previous one.
I'm sorry, John. Description.
No, just on the previous image. Sorry, where you have the heart-based tumor. Should we add as well? There is some sort of thickening of the tricuspid and the mitral valve with. It looks like to me a little bit irregular and some sort of myxomatous disease on both valves.
I can't exclude it's possible, because I agree with you. Both atrioventricular valve in this dog are not severely, but moderate thickening of the leaflet. Yes, it's possible, but take care because it's not the main focus. Do you remember last year I suggested to you think about the elephant, not about the insect. Think about the elephant, and later think about the mouse. And that's the main focus, is the nodule. Jonathan, what do you think about this picture?
Well, okay. So this picture we can see a valve. So I guess we have to figure out where we are. So looking at the valve, to me it looks like a mitral valve. So we are probably inside the left atrium, and we can appreciate.
Sorry, Jonathan. Which is the point? Sorry. Which is the point of view?
From the left atrium. So we are inside kind of the left atrium, and we can see the both leaflet of the mitral valve, and so down there is probably the left ventricle, because we can see when the mitral open, so the kind of nodule thickening is going to like a down. So that makes sense. We are in the atrium here.
Okay, so the point of view is dorsal.
Yes,
that's dorsal.
Dorsal in the left atrium.
Yeah, that's the caudal margin. Did you see the laser? That's the caudal margin. Here there is the interatrial and eventually the interventricular septum. So that's the septal leaflet of tricuspid valve, and that's the parietal leaflet of tricuspid valve. Okay. It's important try to put in a correct anatomical situation.
So you said tricuspid valve, but I would have said mitral here.
Why tricuspid valve? It's clear that I see two leaflets, and also look around. In tricuspid valve, in some portion here, for example, I have to see the coronary sinus.
But you cannot. Can you see the coronary sinus here?
No, there is not a coronary sinus.
So it's mitral valve then.
Yeah, that's a mitral valve, sure.
Okay. Because you said tricuspid, that's why I was confused. Sorry.
No, I make a mistake. I'm sorry. That's a mitral valve.
All right. We agreed. So we are inside the left atrium, and obviously we can see the anterior leaflet and the posterior leaflet. We know that usually the anterior leaflet is a bit bigger than the posterior. So I would say the one that we see down is probably the anterior leaflet, and the one that is up is probably the posterior leaflet. So I might be wrong. But if we look closely, we can see that this valve is irregular and thickened, and there is not an optimal coaptation here. But that's a bit subjective, obviously. We can see as well on the right, there is a little cordia tendine that is probably ruptured as well. And finally, if I describe the wall of the left atrium, it's irregular. So the color is within normal limits, but there is an irregular and thickening of the atrial wall that could be, I think, consistent with jet lesion. So my most likely diagnosis would be mitral valve disease, so moderate to severe with rupture of cordia tendine and left atrium dilatation with jet lesion.
Okay, perfect. I agree with you. Any question? Everything is clear?
Yep.
Good. Another one. Ursula, there is Ursula. Is there Ursula? Oh, non so.
Massimiliano, sorry, Ursula told me that maybe she... you are here. Sorry, Ursula. Because...
So I needed just time to
Ciao, Ursula. Come stai? How are you?
I'm okay, thanks, Massimiliano. I hope you're well too.
Yeah, everything is okay. Nice to see you, more or less to see, because I don't see nothing, but to meet you again.
Look, we can see each other. Just let me do some.
Okay.
Can you see me now?
No, I can't. I can't to see nothing. I can't. I can't to see just my presentation. But anyway.
Okay. Try to turn on my camera, but maybe you can't see me. I don't know.
No. I can't. No. Okay, Ursula, what do you think about this picture, this finding?
Well, for sure we can appreciate here atrioventricular valve. That's again, I would say that it's mitral valve, isn't it?
Yeah, is it correct?
And the leaflets are shortened and thickened and irregular. I can't see any discoloration, but I can't see as well any proper chordae tendineae. And the leaflet looks for me very shortened. I would rather guess that's like a congenital malformation, because that will be my differential, because if I can't see really normal connection between the mitral valve leaflets and papillary muscles, and this is like the border of the leaflet is like directly connected to the myocardium, to the endocardial layer of the ventricle. The endocardium in the ventricle looks normal, and the endocardium in the upper part of the image, it's the atrium. It looks normal. I can't see any jet lesions or anything like that. Then, of course, my diagnosis or my description would be malformation of the atrioventricular of the mitral valve, most likely the congenital one, not degenerative, but I don't know if I'm right.
Is it correct? But which is the specific name of this malformation? Dysplasia.
Dysplasia, mitral valve dysplasia.
Mitral valve dysplasia. And that's because, of course, there are not chordae tendineae, because there is a direct insert between the leaflet and what looks a papillary muscle. Because, mitral dysplasia, atrioventricular dysplasia, it could be present in every part of the valvular apparatus. So, in this case, the main findings are on the structure of the leaflet and on the growth of the volume of the length of the chordae tendineae. And so that's correct. That's correct. Look, is normal, the endocardial layer is normal. And it's normal.
I think the leaflet itself is like a thickened and irregular too. The leaflet doesn't look normal.
Yeah, and it's a thickening, something like a nodule, because if we make the histology in the leaflet, there is myxomatous tissues. The myxomatous tissue is a reaction of the leaflet, in particular in the degenerative process. But there is also in congenital disorder, like in this case. In this case, the pathogenesis is not so clear, because we are not many information about the myxomatous tissue in this plastic valve. It could be a intense disorder, intense acute activation of the interstitial cells. It could be, or it could be also a embryonal myxomatous tissues. Maybe there is also an embryonal component because of the malformation. I don't know why, but I'm sure that is because there is myxomatous tissues. Anyway, for your examination, describe, like Ursula, the morphology and the correct diagnosis mitral dysplasia. And we don't see very well, but just a little, the shape of the left ventricle is not so clear. But in this case, of course, there is an insufficiency of the valve and, of course, a volume overload of the ventricle. So with eccentric hypertrophy and in chronic situation, in chronic stage, dilatation. Any question? Any comment?
I think Fabio had a question.
Yes.
He's got some issue with the mic. He wanted to know how can you differentiate between mitral valve and tricuspid valve in this case?
Good question. And for example, here, look here. You see there is a space between the valve and the wall of the cavity. For example, the question is correct. That's not a perfect, a good presentation. It's not correct to put in for your examination, for example, but for this particular, because there is the space, the empty space between the leaflet and the wall, and that's because it is the outflow tract of the left ventricle. Because as I told to you, between this leaflet and that's the septal leaflet, because I cut the caudal margin of the ventricle. Usually we cut the caudal margin of the ventricle. And that's the papillary muscle. And this papillary muscle very close to the morphology of the left ventricle. And here that's the septal leaflet, and there is empty space. There are not direct joint with the chorde tendine because it's an anterior leaflet. Fabio, what do you think? Or Jonathan?
Massimiliano, sorry, maybe Fabio has a tech issue. Just 2 seconds. Fabio, I open your microphone. Can you try to speak, please? It doesn't work. Okay, we will solve during the break. So Fabio is writing in the chat, and we try to get you, Massimiliano, his comment. Okay.
I was thinking as well, we could add the fact that we cannot see the trabeculae as well, so maybe it could be another argument to say this is a wall of the left ventricle. I don't know if that's correct.
Yeah, it's correct. But I agree with you, it's not a correct presentation for identify the specific atrioventricular valve. I agree.
Massimiliano, can you hear me?
Sure.
Actually, I wasn't that sure if this is the left ventricle. From that reason, I was asking you at the beginning if I'm right, if this is the mitral valve. My way of thinking was because I would expect the inside, the endocardial layer of the left ventricle to be more smooth. And this surface looks a little bit like trabeculation, but it's too less for a general trabecula for me. And I thought it's maybe pectinate muscles, and it was rather driving my attention more to the left ventricle, not to the right. Am I wrong or right? Or
yeah, it could be, Ursula. It could be pectinate muscle. No, I don't think it's the case to think about the pectinate muscle, because it's clear that dorsal there is the atrium and ventral there is the ventricle. And in the middle, some kind of atrioventricular valve. I think that this orientation is clear.
Yeah, that's okay.
And so also the ventricle is not
only in the atrium. We don't have them in the ventricle.
Again, Ursula?
And the pectinate muscle, they are only in the atrium.
Right. Remember, the pectinate muscle only in the auricle.
On the auricle,
only in the auricle, not in the ventricle. In the ventricle, we have the papillary muscle, also other kind of trabeculation, but not the pectinate muscle.
Okay, thank you.
Okay, here there is also histological finding, but anyway, we need to introduce also this part that you will be in the later after the lunch. We want to try. It was a cat. There is a gross finding with a transversal cut section, and of the same finding, we also do histological presentation. Who want? Don't be shy, please. That's your turn. Don't worry if you say or if you think it's not right. Don't worry.
Hi, everybody. It's Julie. Can you hear me?
Julie, ciao. How are you?
Hello.
Good.
I'm good, thank you. Hope you're okay. I thought I would give this a go. I probably won't be very good. So on the gross pathology image, I think that generally the myocardium looks discolored or patchy in appearance. Is that real, or is that to do with the fixation of the sample?
No, is it correct? Of course, there is also a fixed discoloration, but you see the whitish discoloration is not uniform.
Mm.
In case of discoloration because of the formalin fixation, usually is uniform. In this case, is not uniform, is irregular, the whitish discoloration. And so it's a real, it's interesting, and it's the focus.
Fine. And I think that so we're looking at the left ventricular cavity and then the right ventricular cavity. Is that right?
Yeah.
The left on the right image.
Yeah. So sorry, just to comment the presentation. There is a little deformation of the heart, and that's because the colleague put in the formalin, but in the small box, and so there is some kind of alteration for the shape. Anyway, the cut section is that's the right ventricle, that's the interventricular septum, that's the left ventricle. I think it's clear.
I'm not sure if you can say or not, but does the left ventricular wall look concentrically hypertrophied? I think I'm just guessing because it's a cat.
Okay, that's a good question. But if you see also there is the mark, if you take a look, more or less the 5 millimeters, more or less. Maybe more. Okay.
And then looking at the histopathology images.
No, sorry, one more description about the gross pathology.
One more.
A little more. about the distribution of the whitish discoloration.
So I suppose, is it more obvious towards the left ventricular free wall? I'm not sure.
Yeah, here, yeah.
Uh-huh.
But also here. Also here. So there is not
sub endothelial, then that makes sense.
So multifocal. There is not only a specific area of the wall. Multifocal whitish discoloration, and these patchy discoloration are irregular. The margins are not so clear.
Okay. So more of a generalized pattern.
And on the right, and we introduce the histological part of the workshop and also of your examination. are two histological presentations, of course, of the same heart. The heart with hematoxylin and eosin stain. That's a basic stain for histology. With the stain, the sarcoplasm is pink. The nuclear material in general are purple. And but we speak better later about the histology. What is evident in both histological presentation is between the myocardiocytes, and they are in longitudinal presentation in this picture. You see all the sarcoplasm, and in the middle of the cardiomyocytes, and is more clear here, there are cellular infiltration. And the morphology of this cellular infiltration is round cells. Here there are round with central, paracentral nucleus, and large eosinophilic, and so pink cytoplasm. That's all the mononuclear infiltration in case of myocarditis. In case of non-purulent myocarditis. I will speak again about the histology. Don't worry. That's just to introduce the argument, because I know that for your examination you have some histological picture. Also for the mock exam, or tomorrow, we have some histological picture. The program tomorrow in the afternoon, we have a mock exam with a simulation. And another particular of this picture is also the vessel, many vessels around the leukocyte infiltration with a lot of red cells. That's hyperemia around the leukocyte infiltration. So that's a presentation, but I think that it's necessary, or there is a gross end histology, so it's clear that we are speaking about myocarditis, or if you see for your examination only this kind of presentation with whitish discoloration, multifocal margin, and such, most likely it could be non-purulent myocarditis, and non-purulent because there are not abscess. It could be fibrosis, or it could be degeneration, or it could be also some neoplastic lesion, also some neoplastic metastasis, for example. So if you see gross end histology, you may to say that's a myocarditis. What do you think about this comment, this picture? Any question? Okay, here we are.
Sorry, Massimiliano, can I ask? So if we have a whitish discoloration, what are the differentials you said? You said fibrosis, you said infiltrate with white blood cells, and did you say fatty deposition or fatty replacement as well, or?
Okay, fatty replacement is not the most likely presentation, because it could be. Why not? When I see some whitish.
Massimiliano, not in this case specifically, but if you see white discoloration in a ventricle, could we think about adipocyte deposition in general?
In general, yes, of course. And of course, if we speak about fat infiltration, we are speaking about RVC, cardiomyopathy, of course. But you know, there are some clear, correct, and specific gross and histological presentation of RVC. That's an important concept. For every abnormality, for every pathology, I think it's necessary correct presentation and also specific presentation. For example, for fat infiltration at the gross examination, it's necessary to see a transmural point of view. What's meaning transmural? From epicardial to endocardial. That's a correct presentation. If we speak about necropsy. Different if we speak about endomyocardial biopsy. There is in this case a different point of view, of course. What do you think, Joao? It's clear my comment?
Yeah. I was just thinking if I have a case where I am not sure what it could be. Obviously, with ARVC, I would expect thinner walls and obviously probably affecting more the right side eventually. But I was just thinking about in general whether if you have the position of adipocytes, it will look like a yellowish or whitish discoloration. I will just double check that.
Yeah, usually it's not so specific in case of fatty. Generally speaking, fatty accumulation is not so typical. Multifocal area usually are a single, very clear area of fat infiltration.
Okay, thank you so much.
Usually.
Massimiliano?
Yeah, Ursula.
Yeah, that's Ursula. Just looking on the left side on the gross pathology, if I wouldn't have the histopathology in this case, my first differential would be like infiltrative disease, lymphoma, because of the myocardium being very irregular and patchy, and I don't know. I would expect, but probably I'm wrong, if you have myocarditis, that should be more homogeneous for me. And this was quite really irregular, and it involved the right heart as well, and the papillary muscles are irregular. Wouldn't be this correct having without the histopathology to have the infiltrative disease quite high on the differentials? If we would see only the gross pathology?
Okay, there are some good question, Ursula. I agree with you. In particular, in the cut, if you see a cut section, but also external surface of the heart, and if you see whitish finding, whitish lesion in general, it's important and it's interesting to think about infiltrative process. And of course, if we think about the line, the cut, we think about the lymphoma. But in case of lymphoma, you have to think, you have to see, to observe very, very solid whitish portion, compact nodules, transmural whitish compact area. In this case, I can't suppose not lymphoma, because a lymphoma usually is of course, infiltrative process, but also from your point of view, it could be also a pseudo-hypertrophy. And so there is a severe, very clear thickening of the wall with nodule, with mass, very, very fluid, very solid. But in general, I agree too. A general concept of infiltrative process, it's mandatory. It's mandatory. And for infiltrative process, we have to think inflammatory process and neoplastic process. But in case of lymphoma in cat, are more whitish and more solid. I will show you some picture.
Okay, thank you very much.
But in general, in differential diagnosis, I agree with you. Fibrosis, summarizing fibrosis, infiltrative process, and with infiltrative process we mean inflammation and neoplastic finding. Any question?
Thanks.
Okay, another case. We have more or less, again, 10 minutes before the lunch and before the relax time. So, don't be shy. I like to listen another voice.
Hi, I'm Gita. I can give it a try if you want.
Sure.
So I think, can you hear me?
Okay, we are looking which part of the heart?
So we are looking at from the left side.
That's correct.
Okay.
From the auricular surface of the heart. That's correct. Which is this anatomical? Look here. Which is this one?
That's the. Is it the? Oh, wait, no, I don't remember.
Yeah, that's the interventricular groove, interventricular sulcus, and in this phase is the paraconal. Why the name paraconal? Paraconal. That's the conus arteriosum of the right ventricle. And so paraconal, because it's parallel, is close to the conus arteriosum. That's the name paraconal. Do you understand me?
But you're looking at the left side here, right?
Yeah, that's the left or auricular surface of the heart when there is a dorsal portion or atrial auricular portion and a ventricular portion or ventral portion, and along the ventral or ventricular portion there is a interventricular sulcus groove, and the name is paraconal groove. Paraconal groove because it's closer to the conus arteriosum of the right ventricle. That's the outflow tract of the right ventricle, and cranially to the paraconal groove, and caudally to the paraconal groove we have the left ventricle.
Oh, yeah, okay, like this.
Okay? Don't worry, we repeat the information. Don't it's not a problem.
So in general, then I think we have an enlarged heart. In general, I think it's mostly the right side involved. What you can see here, at least. Yes.
Yes.
And then.
Which is this part?
Then that should be the right auricular appendage.
Sure. And what do you think about this right auricular appendage?
That it's really huge.
It's incredibly huge. So there is a severe dilatation inside. And what about the ventricle? The right ventricle?
Too. For me, it looks dilated too.
Okay, dilated. If you don't cut the ventricle, you cannot to say dilation or hypertrophy.
Yeah.
Basically, you can to say there is an enlargement of the right ventricle. That's the second point. There is another abnormality, another finding to observe.
Do you mean a pulmonary artery? Maybe?
Sure, of course, because the disorder is on the right, and so I'm looking for the atrium, auricle, I'm looking for the ventricle, and of course I have to look for the pulmonary artery. And what do you think about the pulmonary artery?
For me, I think the what's coming to us, let's say, it's the right side, right? The right branch of the pulmonary artery.
No, no. Here we see just the pulmonary trunk. Here, that's the aorta.
Mm-hmm.
That's the aorta. That's the first portion of the ascending aorta. That's the arch of the aorta with the brachiocephalic trunk and left subclavian artery. And that's the first portion of the thoracic aorta. But externally, on the left, we see the pulmonary artery. In particular, we see the pulmonary trunk here.
Oh yeah, okay. So you can
Okay. And what do you think about this pulmonary artery in general?
I just have one question. What is it then above the aorta that we see? Is it still part of the atrium then?
This one, the aorta.
Yeah, but then above the aorta.
Above the aorta. That's the pulmonary.
No, on top of it.
On this one?
Yes, then it's part of the atrium still.
This one is the cranial cava vena. That's the cranial. Here there is the sulcus, the terminal sulcus. That's the cranial cava vena.
But that's also arch then.
That's the aorta.
Mm-hmm.
That's the pulmonary trunk. And here we see a small portion of the left auricle, very small portion of auricle. So the point of view is left and also a little cranial. So which is your comment? Why there is a right auricle dilatation, right enlargement of the right ventricle, and this finding in the pulmonary trunk? Which is your interpretation about the pulmonary trunk? Why there is this kind of shape and volume?
I would say that the pulmonary trunk looks still quite normal, no? Or is it? I'm not sure.
No, it's not normal.
Okay, then
it's not normal. Other question for other colleague?
I have the impression that it's quite small. My first impression would be it's hypoplastic, but maybe I'm wrong because the right side is so huge that it's make the impression of it being like displaced and small.
But Ursula, what do you think about the pulmonary trunk? For you, is normal, is biggest or is smallest?
I would say it's rather it's for sure there's for sure not, but I think there's a stenotic lesion. But I'm not sure if the whole main pulmonary trunk is hypoplastic.
Hypoplastic? I think no. Hypo is small, but I think that in this picture the pulmonary trunk is particularly evident. That's a dilatation of the pulmonary trunk. That's a dilatation.
Okay.
And it's because there is a pulmonic stenosis inside. Of course, we don't see the pulmonary valve, of course, but why there is a right auricle dilatation, right ventricular enlargement, and increase, so dilatation, ectasia of the pulmonary trunk. Usually it's because there is a pulmonic stenosis inside. That's the external presentation of the heart in case of pulmonic stenosis. Other question?
Maximiliano, I also had this question about the dilation of the pulmonary trunk. I mean, what I have done is try to compare the size of the pulmonary trunk against the aorta. And maybe it's a bit more dilated, but I'll also be in an exam situation. They don't look so different on the picture, so I'll also be struggling about. And there is an area where I think is where we can see the left pulmonary artery coming out, and that area seems to me a bit more rounded and dilated. So, but I would struggle as well in an exam situation if the size between the aorta and the pulmonary trunk are not very different.
Yeah, it could be, but of course, yeah, I agree. But in this case, we don't see very well the aorta.
Yeah, exactly.
Yeah, in this picture, we don't see very well the aorta.
I have to say, I try to do the same. I try to compare the size of main pulmonary trunk to aorta, and to it post-stenotic dilation, I would expect to be bigger. And in this situation, I had the impression from this point of view that it's the same size or even smaller. And then I just started to think that it's not only pulmonic stenosis, but maybe hypoplasia of the pulmonary artery too. But probably it was too long shot.
Yeah, hypoplasia of the pulmonary trunk is a good question. But you have to see a very, very small pulmonary trunk. So I think that in this case, maybe is not the best point of view. Maybe there are also much more severe post-stenotic dilatation. Of course, it's possible, but I think it's so. In my point of view, it's enough clear the enlargement of the pulmonary trunk. But anyway, it's a point of view. It's a point of view, and maybe for your examination, it could be more correct to put a very, very clear presentation.
Thank you.